during COVID-19. My name is Anne Detjen. I'm a child health specialist at UNICEF headquarters, and I will be facilitating this session with Pavani Ram, Senior Medical Advisor for Child Health at USAID. The two of us are co-chairing the Pediatric Quality of Care subgroup of the Child Health Task Force, which is co-organizing this series with the Network for Improving Quality of Care for Maternal, Newborn and Child Health. Bienvenue à tous au 7e et dernier webinaire de notre série sur la fournir des services de santé maternelle, néonatale et infantile essentiels de qualité pendant le COVID-19. Je m'appelle Anne Detjen, je suis spécialiste de la santé infantile au siège de l'UNICEF et animerai cette session avec Pavani Ram, conseillère médicale principale pour la santé infantile USAID. Nous présidons toutes les deux le sous-groupe Qualité de soins pédiatriques du groupe de travail sur la santé des enfants, qui co-organise cette série avec le Réseau pour améliorer la qualité des soins pour la santé maternelle des nouveau-nés et des enfants. All slides are going to be bilingual. We will translate additional key messages conveyed by the speakers in English or French respectively in the chat box. All questions and answers in the Q&A session will be translated live. Toutes les diapositives sont bilingues. Nous traduirons les messages clés supplémentaires transmis par les intervenants en anglais et français respectivement dans la boîte de discussion. Toutes les questions et réponses de la session pendant la discussion seront traduites en direct. Next slide, please. Service disruptions and broader measures put in place to control the COVID-19 pandemic require constant evaluation and adaptation of the quality and delivery of maternal, newborn, and child health services. This series aims to highlight opportunities and learn from countries on their approaches to maintain essential routine care for women and children. Les interruptions des services et les mesures mises en place pour contrôler la pandémie de COVID-19 nécessitent une évaluation et une adaptation constante de la qualité et de la prestation des services de santé maternelle, néonatale et infantile. Cette série vise à mettre en évidence les opportunités et à apprendre des pays sur leur approche pour maintenir les soins de routine essentiels pour les femmes et les enfants. Next slide, please. This final webinar will focus on ICCM and IMNCI as essential primary healthcare services for sick children, delivered at frontline facilities and the community level. Ce dernier webinaire pour sujet la prise en charge intégrée des maladies des enfants et la PCM communautaire comme service de soins de santé primaire essentiel pour les enfants malades. Our first speaker and moderator is Tamar Chitashvili, Technical Director for Maternal, Newborn and Child Health at Chorus International and the Maternal Newborn Health Team Lead for the USAID Momentum Integrated Health Resilience Project. She will set the stage and moderate the discussion. Ensuite, l'équipe du Sénégal va partager ses expériences représentées par le Dr Amadou Doucouré, directeur de la Direction de santé de la mère et de l'enfant au ministère de la Santé et de l'Action sociale du Sénégal, et Dr Aïssatou Diop, chef de la division survie de l'enfant dans la même direction. This will be followed by experiences from Uganda, presented by Dr. Flavia Mpanga, acting RMNCAH manager at UNICEF Uganda Country Office, and Dr. Maureen Amutuhaire, the National ICCM Coordinator at the Malaria Control Program, Ministry of Health, Uganda. At the end, we will have a question and answer session. You can ask your questions and share comments in the chat throughout the webinar. À la fin, nous aurons une session de questions et réponses. Vous pouvez poser vos questions et partager des commentaires dans la boîte de discussion tout au long du webinaire. With this, I hand it over to Tamar. Je passe maintenant la parole à Tamar.
Good morning, good afternoon, colleagues. It is an honor to moderate this important webinar focused on maintaining essential child health services in the context of COVID pandemic. We know that in any crisis, the young and the most vulnerable suffer disproportionately, and COVID-19 is not an exception. The direct impact of COVID-19 infection in children has been far milder than for other age groups. However, children are the hidden and one of the most severely impacted victims of COVID-19. Children are affected through different channels. exacerbated poverty, reduced learning, nutrition, safety, survival, and health. International Monetary Fund's modeling suggests that just because of reduction of GDP growth, hundreds of thousands of additional child deaths could occur in 2020. COVID-19 is adversely affecting health systems, particularly in low and middle income countries. Prior to COVID-19 crisis, 32% of children worldwide with pneumonia symptoms were not being taken to the health provider. What happens to pneumonia and diarrhea care seeking and continuity of services during COVID-19? What happens to continuity of care for non-acute essential well baby care? What about quality of care? We are already seeing disruptions in immunization services, threatening outbreaks of diseases such as polio and measles. Today, we will try to shed light some of these questions while focusing on maintaining continuity and quality of essential child health services close to homes, at primary care and community levels. Many low and middle income countries have long history of implementing integrated service delivery platforms such as integrated community case management, ICCM at community level, and integrated management of newborn and childhood illnesses, IMNCI at primary care level. The package of IMNCI and ICCM varies country to country, but it commonly includes preventive practices like routine growth and developmental monitoring, breastfeeding and infant feeding practices, identification, initial treatment and referral of children with signs of severe illness, and management of common illnesses like diarrhea, pneumonia, and malaria. Bringing integrated services for preventive and curative care for common childhood conditions close to communities have potential to increase not only availability of child health services, but also all core domains of quality of care, continuity of services across community facility levels, timeliness, patient-centeredness, efficiency, equity of coverage, and most importantly, effectiveness of child health services to prevent morbidities and childhood mortality. COVID poses unique challenges to achieve these objectives and ensure continuity of quality of ICCM and IMNCI services due to many supply, demand side, and systemic factors affecting all key aspects of quality of care. To unpack these factors, let's first look at the pediatric quality of care framework developed by WHO. Many of you know this framework very well. It places equal emphasis on provision and experience of care, along with human and physical resources to improve individual and facility level outcomes. As you could see, among 8 standards of quality of care, 3 are related to provision of care, and 3 refer to experience of care for children and their families. All these standards could be severely affected by COVID pandemic, suggesting potential dramatic impact of epidemic on pediatric quality of care and health and patient-centered outcomes. For example, let's look at the supply side factors. COVID-19 brought the agenda to rapidly adapt care guidelines, pathways, and process flows, including those related to differential diagnosis with conditions having similar symptoms like fever. Disruption of community facility linkages and existing communication and transportation systems may challenge the referrals and continuity of care. Reduced number of workforce due to COVID-19 infection, increased workflow and redeployment, greater needs of IPC and personal protective equipment, and reduction in supply chains may affect availability of essential physical and human resources in health facilities. Limited data on district-level COVID-19 surveillance and response may make it difficult to support local planning and rapid adaptation. Now let's look at demand-side factors. Potential fear of using health services, limited awareness of COVID preventive measures, stigma, may prevent children and their families to seek essential child health services. From previous outbreaks, we know that movement restrictions, loss of income, isolation, high levels of stress and anxiety are increasing the chances of children experiencing and observing physical, psychological, and sexual abuse at home. Increased stress among children, caregivers, and families also pose significant need to provide emotional and psychological support and protect child's rights to maintain their cognitive development, physical health, and prevent longer-term mental health challenges. All these barriers affect not only quality, but also continuity of child health services and care-seeking behaviors. And most importantly, these undermine many of the gains made in child survival, health, nutrition, and development over the last several decades. Modeling studies suggest that reduced coverage of 3 child curative interventions account for 40% of additional child deaths. Sharing the lessons to maintain essential child health services in the context of COVID through ICCM and IMNCI platforms is critical for effective and timely global COVID response to protect our future. We hope that today's presentation from Uganda and Senegal team will help to spark some ideas to scale up successful practices and learn from these experiences. Thank you. Now I will pass to Senegal team, Dr. Doucouré.
C'est Dr Amadou Doucouré, je suis le directeur de la santé de la mère et de l'enfant. Chers participants, au nom de Monsieur le ministre de la Santé et de l'Action sociale du Sénégal et de Madame la directrice générale de la santé, je voudrais remercier le groupe Child Health Task Force et le sous-groupe Qualité des soins pour les excellentes initiatives. Le Sénégal est honoré de partager son expérience. Par ailleurs, je voudrais vous informer aussi que nous recevons les informations à travers les pays membres et nous vous en félicitons. Le Sénégal s'est engagé à atteindre la cible 2 des objectifs de développement durable, qui est d'éliminer les décès évitables des nouveau-nés et des enfants de moins de 5 ans. Et selon les projections faites au niveau du pays, si toutes les interventions et stratégies prévues sont bien menées, le pays peut réduire la mortalité infanto-juvénile et atteindre l'objectif de 20 pour 1000 en 2030. Malheureusement, comme vous le savez, le Sénégal, à l'instar des autres pays, est confronté à l'épidémie de Covid-19. Et le 2 mars 2020, nous avons enregistré notre premier cas de Covid-19, ce qui a créé un peu une perturbation de notre système de santé. Mais face à ce fléau, nous avons été instruits d'accorder une attention particulière pour la continuité de service. C'est bien de prendre en compte, de gérer cette pandémie, mais aussi le ministre nous a instruits de prendre en compte les autres pathologies mortelles et de mener à bien nos programmes de santé. C'est dans ce cadre qu'un dispositif stratégique avec élaboration de documents, suite à une évaluation de l'état des lieux de la mise en œuvre des programmes au niveau des régions, nous avons élaboré un document, un plan de contingence qui a été partagé avec tous les acteurs du système et même partagé à un autre niveau, au niveau du Conseil économique, social et environnemental, avec l'ensemble de ces conseils. Et ce plan de contingence a été élaboré et actuellement est en train d'être mis en œuvre au niveau de ce sanitaire, avec comme élément fondamental la mise en œuvre d'un guide sur la continuité des soins santé reproductive, maternelle, néonatale, infantile et de l'adolescent. Et à ce jour, nous avons aussi pris comme stratégie de mesurer day to day ce que nous sommes en train de faire. Et cela se traduit par le suivi des indicateurs clés, mais aussi l'analyse des données qui se fait de façon périodique avec une rétro-information et feedback au niveau opérationnel pour que des dispositions correctrices soient prises pour améliorer ces indicateurs, mais aussi pour essayer de se rattraper par rapport à ce que nous avons perdu durant la phase intensive de la COVID-19. Ces activités se mènent soit en semi-virtuel, mais aussi bien en semi-présentiel. Et nous insistons aussi sur un aspect fondamental, c'est sur le partage hebdomadaire des décès maternels et néonatales et les stratégies qui sont en train d'être mises en œuvre au niveau des régions et au niveau des districts sanitaires. Donc, c'est pour vous dire que le ministère de la Santé et de l'Action sociale a tenu quand même à garantir la continuité et la qualité des soins offerts en faveur des mères, des nouveau-nés, des enfants et adolescents pour la satisfaction des populations qui sont notre raison d'être. Je pense que tout ce que nous sommes en train de faire doit être centré sur la population. Et à ce titre, nous allons partager avec vous ce qui a été fait durant cette phase d'épidémie de COVID-19, mais aussi dégager avec vous les perspectives et les défis, ce qui nous permettra quand même d'aller de l'avant. En tout cas, je souhaite une bonne continuation et je vous ai donné la parole à Dr Aïssatou Diop, qui est la chef de la division de la suivi de l'enfant au sein de la direction de la santé de la mère et de l'enfant pour que le partage soit fait. Je vous remercie de votre aimable attention. Merci.
Avec vous, la situation de la continuité des soins pessimée en période de pandémie. Nous allons voir ensemble le contexte, la situation des indicateurs clés, les nouvelles dispositions et adaptations prises, les défis et leçons apprises. Le contexte est déjà connu, le Sénégal s'est aligné au niveau mondial. On était dans cette dynamique et lorsque le premier cas de Covid est survenu et qui a perturbé quand même le système de santé. On le voit à travers ce graphique où la consultation des enfants malades a drastiquement baissé au trimestre 2 de cette année. Concernant les indicateurs de prise en charge des enfants malades, pneumonie, diarrhée et les soins essentiels du nouveau-né, les tendances n'ont pas changé. Quel que soit le trimestre, on a eu pratiquement les mêmes performances. Il y a un indicateur qui a attiré notre attention sur la qualité des soins. On voit que la performance s'est beaucoup améliorée au deuxième trimestre pour la recherche des signes généraux de danger. Nous sommes en train de poser des hypothèses pour voir réellement pourquoi durant la période de Covid, on a eu cette meilleure performance. Pour la vaccination, nous avons pris 2 indicateurs traceurs, penta 3 et rougeole. Là aussi, on voit que durant le trimestre 2, les chiffres ont baissé. La fréquentation des services de vaccination a beaucoup baissé, mais actuellement, avec la rougeole, la tendance évolutive a repris son envol. On est en train également de poser les hypothèses, mais on a vu que c'est plus simple de rattraper tous les enfants pour la rougeole rubéole, parce que tout peut se faire en même temps, alors que pour penta 3, c'est une série. Il faut progressivement faire le 1, 2, rattraper tout cela avant d'aller au 3. On a discuté et partagé avec le programme qui s'occupe de la vaccination et on est en phase. Le dispositif stratégique et opérationnel est en train d'être mis en œuvre. Ce qu'on a fait dès le départ, c'est des missions de suivi pour voir l'effectivité des services et cérémoniaux durant la période d'épidémie. Nous l'avons fait en collaboration avec les régions médicales et tous les partenaires techniques et financiers de la santé de la mère et de l'enfant. Il y a eu des adaptations. Pour ce qui est de la pessimie clinique, la première adaptation, c'était de respecter les mesures barrières et pour le personnel et pour les parents en vue de protéger l'enfant. Il y a également une innovation de taille, c'est l'utilisation de téléphone pour faire le suivi des enfants malades. En tout cas, ceux qui ne sont pas gravement malades, pour les rendez-vous, ça s'est fait au téléphone. Il y a également au niveau local beaucoup de solutions innovantes qui ont été apportées, telles qu'une région qui a partagé avec nous le système d'appel transport durant la période de couvre-feu où les femmes enceintes en travail ou en urgence faisaient appel à ce système. La coordination, les réunions se sont faites en ligne. Là aussi, ça a été une grande innovation de taille. Avant, c'était toujours présentiel, mais durant la période chaude de l'épidémie, nous avons tenu nos réunions en ligne. D'ailleurs, ce qui même continue actuellement. Concernant la pessimée communautaire, toutes les stratégies de proximité ont été maintenues, mais sécurisées et adaptées au COVID. Il y a eu également une innovation, la promotion de l'œuvre-soin avec un paquet familial normé. Le cas du Sénégal, on a ce qu'on appelle les marraines de quartier qui ont été déployées dans tout le pays. Ce sont des femmes leaders qui appuient de façon bénévole, sensibilisent, font le plaidoyer et accompagnent les communautés à avoir des comportements adéquats. Pour le cas de l'immunisation, la grande adaptation, c'était de diminuer le nombre d'enfants regroupés pour la vaccination. Mais nous avons envoyé des notes ministérielles et une communication intense pour faire revenir la population dans les services de consultation de l'enfant sain. Et pour rappel, en plus de la vaccination dans le paquet, on avait également la vitamine A, le déparasitage et même d'autres interventions. On a eu la chance d'avoir des facteurs qui ont facilité la continuité des soins pédiatriques. C'est avec l'approche participative, tout est intégré déjà dans le système pour la PCV. Le registre de consultation enfants malades, les indicateurs. Également, on a pris de nouvelles mesures en intégrant l'oxygène dans les documents de formation de la PCV, mais aussi on a intégré les standards qualité de l'OMS. Et surtout, là où la référence n'est pas possible, que faire? Surtout pour le nouveau-né. Là aussi, ça a été fait. Il y a également un système de réseautage et de parrainage en place. Les défis que nous devons relever ensemble, c'est la disponibilité du matériel de protection, particulièrement pour les acteurs communautaires à qui on demande de se déplacer. Également, la disponibilité des médicaments. De l'autre côté, nous devons relever la demande. Également, augmenter, faire de telle sorte que l'acceptabilité de la communauté pour utiliser ces services, surtout qu'il y a des moments où il y a eu des rumeurs et des réticences. Et enfin, la qualité, qui est une grande priorité du système de santé actuellement, nous devons y veiller, quel que soit le contexte, pour la satisfaction des bénéficiaires. Et comme le sont apprises, nous savons que les services ont été disponibles à tout moment, mais il y a eu une sous-utilisation de ces services. Il y a eu des engagements communautaires et une participation communautaire forte avec des solutions locales innovantes. Les prestataires également se sont mobilisés et les associations corporatives pour faire des déclarations d'engagement. Les TIC, là vraiment, c'était l'élément, la grande innovation. On a augmenté l'utilisation des TIC durant cette période. Aussi, on a essayé d'adapter notre communication parce qu'au début, l'effet, c'était une grande psychose dans le pays, mais finalement, on s'est ressaisi pour adapter la communication. En conclusion, l'enfant est hyper vulnérable à toute période, surtout en période d'épidémie. Donc, nous devons exiger la continuité des soins pour offrir un paquet essentiel et un paquet spécifique à tout enfant malade, en vue d'optimiser ce cadre de soins attentifs auquel le Sénégal vient d'adhérer pour aider l'enfant à survivre, à s'épanouir et à se transformer. Je vous remercie.
Thank you very much.
Good afternoon, good morning, good evening, everybody. This is Flavia and Maureen from Uganda, and we're going to be talking to you about how we monitored the continuity of essential health services in the country. We were very lucky that some of the innovations or the supporting enabling environment that happened was that the president endorsed the new community engagement strategy for COVID-19, which where we're going to see community health workers paid a salary by government for the very first time. We have been advocating for this for about 19 years, and COVID was brought the silver lining on such a dark shadow. So the community health workers are going to be paid by government a salary to do risk communication, community engagement, disease prevention, and health promotion activities, including ICCM. We adapted the continuity of essential health services guidelines, which include annexes on RMNCH, IMNCI, ICCM, integrated management of malaria, and taking into consideration the SOPs for COVID-19. The algorithms for treating those 3 killer diseases and also TB were adjusted to take into consideration the COVID aspects. We provided PPE for health workers and VHTs and trained them on the SOPs for COVID-19, social distancing, washing hands, wearing masks, gloves, etc. in order to continue seeing patients and treating people in the community and at a health facility level. We disseminated a lot of messages on malaria, RTI, diarrhea, gender-based violence, violence against children, and generally RMNCH activities by both government and partners and civil society. Now, a little bit of the statistics. We can see here that there was an initial dip in the DPT-3 coverage across the country when the lockdown started in March, April, even for measles, but there was quick recovery. The initial drop was because of the lockdown and access issues. Some health facilities closed for a while, but this was quickly addressed by opening outreaches. Outreaches had been stopped, opened outreaches in the country, across the country, and encouraged all health facilities to provide immunization services on all days of the week, and as opposed to previously where maybe health facilities will provide immunization on only 1 day or 2 days in the week. We can see that the respiratory tract infections that have been seen, there was an initial dip and they have not quite caught up with what the levels we saw in 2019. We are interrogating this data and we postulate that probably is it because people are washing hands, or there is fear among caregivers to take children with cough to the health facilities. That has to also, because they could be mistaken for COVID-19 and put in quarantine. So that may have brought about that. We saw for children treated for malaria with SCTs, there was a little drop, but there's it has gone up, not quite to the 2019 levels, but we've had very extreme climatic conditions with flooding, and malaria is on the uprise. In terms of IMNC's integrated management of childhood services for malaria pneumonia during January to September 2020, we have seen that in the first quarter, and the second quarter were almost similar, but malaria has increased because of the climatic conditions. Pneumonia went down and has come back a little bit, but not as much as in 2019, as we've seen previously. Most significantly, there's been a real downward trend in diarrhea cases seen at facility level. Is this because of washing hands? We are yet to interrogate the data and find out during our qualitative surveys. We have registered a number of, an increase in facility births. That's quite high. You can see the yellow line on top of the blue. 2019 is the blue. Mainly because, especially between May and July, probably the government was able to provide transport services and partners ambulances to deliver mother at health units. And the newborns admitted for inpatient care also increased because we've seen an increase in the low birth weights at the health centers. Utilization of VHT services in the 75 districts out of 135 that are giving ICCM, we saw that the newborns that have been visited twice in the first week of life increased in 2020, mainly because there were more births, but also because mainly because there was improved reporting through the revised HMIS. Utilization, there was a 7% drop in utilization of ICCM facilities services across the country. You can see from 2020, there was an initial 7% drop. 2019, this was because of poor reporting. Now we've got better reporting. And you can see that communities are using VHT services more and more. And now this is also important to realize that the utilization of VHT services between January and September was very high, especially for malaria compared to even the facility utilization, maybe because the facilities were initially closed and then everybody was resorting to the health workers in case of malaria, but there were a few, reductions in pneumonia and diarrhea. Now over to Maureen to talk about the quality of healthcare at the health facility level and community level.
Thank you very much, Flavia. Yes, I'll speak right into the quality of healthcare that was provided at health facilities as well as the community level. And infection prevention and control measures were enhanced at all levels, especially both at the community as well as the facility. And we saw that hand washing equipments were set up, especially at the entrances of all health facilities, but even the community, the VHTs improvised and had hand washing equipments outside their homes. Patient flow changed to ensure safer visits, that is triaging, waiting areas for different symptoms. And a number of algorithms were placed within the facility to ensure that the symptoms were never missed. And if the symptoms were similar to COVID, especially like malaria and cough in terms of like TB, respiratory tract infections, these were changed to show how prompt the health workers needed to look at these symptoms and decide whether COVID-19 was the most probable diagnosis or the other symptom. We also moved into in-depth triaging to rule out COVID-19, and this led to better diagnosis, especially for the respiratory tract infections and malaria. And we'll see that there were quite a number of cases that were identified for TB, especially in the community, because quite a number of people had been maybe coughing, but because now it was a symptom, everyone was on the lookout. If you had a cough, please move to the facility and see what the issue is. So this has increased quite a number of surveillance for some of these respiratory tract infections. I'll move to the next slide, which talks about the VHTs oriented on ICCM and COVID-19. And these different pictorials show us how the different modalities were changed to ensure that there is trainings continue, mentorships continue at the facilities. And for rooms that were small, we see quite a number of people moving into the compound so that they have better aeration, but all in the vein to ensure that the trainings continue during the period of COVID-19. Different innovations at the community level in COVID-19 were also done to enhance its continuity of services. And this is just a locally made TP tap at the VHT home, using just normal timber and a jerry can to enhance hand washing and a placement for soap. And you quickly see that someone can step at the lower stick so that to enhance water flow without necessarily holding the jerry can to prevent contamination. And the next pictorial, we see the VHT trying to administer care to a mother to a child that is brought in by the mother, especially outside the home, still for better aeration and safety of both the mother, but also the child. There was quite a number of cases that we also saw of COVID-19 in our health workforce, and a health worker toolkit was developed to guide on continuity of services in the case of health worker infections. And this was there was a strong focus on infection prevention and control, especially among the health workers, and then risk assessment for exposure. Once a health worker tested positive for COVID, a risk assessment was done, and those that were the contacts and those that were less exposed and asymptomatic were allowed to continue providing care, and those that were symptomatic were allowed to be taken into the isolation units and monitored and tested to confirm whether they have COVID-19 or not, and then enhance continuity of services. Task shifting among health workers and deployment of health workers across facilities in the districts also was done to avoid closure of facilities. And we know that earlier, initially, there was a bit of fear, and if health workers got infected, then there was temptation to close facilities. But there was task shifting made that if a health worker that was in outpatient got infected, then they could take on some health workers from maybe maternity or HIV clinics to come and support the outpatient clinics so that we have these services continue. Counseling was also a very critical area that we looked at for the mental health of health workers while they provide these services, so that we're able to keep them motivated, but also mentally conscious to enhance delivery of service. We faced quite a number of challenges for ensuring continuity of essential health services, and we've broken these into health facility issues and community issues. And at the health facility, we had inadequate PPE supplies, personal protective equipment, fear among the health workers, lockdown that affected access to health facilities for IMNCI services. And we've already seen, as Flavia alluded to earlier, cancelled child health days in April 2020 that affected immunizations at the facilities and outreaches. Increasing number of COVID-19 positive cases among health workers was also a very big challenge in the health facility. At the community, we had shortage of RDTs, rapid diagnostic tests for malaria, because this was global shortage, because most of the manufacturing companies now had moved to manufacturing COVID-19 test kits, and this led to shortage of RDTs within the country. PPEs were also in short supply for also the community, and we had suboptimal supervision by districts. And low reporting rates are registered at the community level. And the lockdown restrictions that limited home visits and community outreaches and restocking as well at the community. We've come up with quite a number of next steps to ensure that there is continuity of services, even amidst all these challenges that we have mentioned earlier. Implementation of the community engagement strategy for COVID-19, and this is what led to actually the salarization that we've seen of the VHTs, as earlier alluded to by Flavia. Revitalization of immunization outreaches, and the community, the child health days have resumed in October and are currently ongoing within the country. We've also had donations coming from direct relief, especially to community, but also more of the personal protective equipment as well to the health facilities. And therefore, assortment of masks and sanitizers are to be delivered to the community health workers. We've also seek to improve availability of medicines and supplies for the VHTs to enhance management at the community level. And also working with these facilities and all levels of care to develop business continuity plans given the high number of COVID-19 positive cases among the health workers. Yeah, thank you very much, and over to you.
Thank you very much for excellent presentations, both to Senegal and Uganda team. Now we open our floor for questions and answers. So Every question will be translated and you will hear both English and French, so that we're able to engage in the discussion. So there is a lot of excitement around Uganda's progress on making the payments for community health workers. So I will just combine the questions around that. So the audience is very much interested how Uganda state managed to pay community health workers a salary, and how did the advocacy work? What was the status of community health workers in Uganda before COVID? Were they paid before? And whether or not this payment is just for during COVID pandemic, or will it continue afterwards?
Thank you, Tama. En français, pour les participants francophones, il y a eu beaucoup de questions dans la boîte de discussion sur le paiement que l'Ouganda a mis en place pour les agents de santé communautaire. Et les questions sont les suivantes. Quel était le statut des agents de santé communautaire en Ouganda avant le Covid? Est-ce qu'ils avaient déjà eu un paiement à ce moment-là? Est-ce que le paiement a été approuvé par le président uniquement pendant la pandémie, ou est-ce que ça va continuer après la pandémie? Et comment est-ce que l'État ougandais est parvenu à payer un salaire à ces agents de santé communautaire? Comment s'est passé le plaidoyer pour en arriver là?
Hello, should I respond from Uganda?
Yes, please.
Okay, good afternoon, good morning, good evening, everybody. This is Flavia from UNICEF, and we are privileged to also have Dr. Jessica Nsungwa, the Commissioner, Maternal and Child Health, on the line. We know that the government recently launched the community engagement strategy for COVID-19, and there was a pronouncement. It was actually launched by the Prime Minister, and there was a pronouncement that the village health teams or the community health workers would start receiving a salary. It was stated that that salary would start in the Kampala district, which is the capital, where we seem to see, I mean, we are in phase 4 of the COVID pandemic, where there is sustained community transmission, but we've been advocating that the community health workers be paid for the work that they do for health promotion and health prevention and ICCM for a very long time. And you may have heard the stories from Uganda where we wanted to emulate what Ethiopia does with their community health extension workers. But this had run into a few issues with the government not committing to pay the salaries. But I think COVID, although it's such a dark cloud, there was this silver lining that it came up with, that now the government for the very first time agreed that they would be able to pay the community health workers for their contact tracing and the risk communication, community engagement effort during COVID-19. And our advocacy has gone ahead to also advocate that the community health workers be paid post-COVID. So the government is going to pay that money from the government's own resources. And there has been a presentation to health development partners in the country to support other aspects of the strategy, which includes the training, adjustments of the job aids for the community health workers. So it is really a breakthrough for us, and we think that we will continue the advocacy so that it lasts beyond COVID-19. But Dr. Jessica Nsungwa may want to supplement.
Thank you. I'm sorry, I need to do the translation before you launch into a more detailed answer. Is that okay? Merci beaucoup pour la question sur le paiement qui va être fait aux agents communautaires de santé. C'est un débat et un plaidoyer qui a commencé il y a très longtemps en Ouganda pour demander à ce que le travail des agents de santé communautaire soit reconnu et payé pour tout ce qu'ils font pour la promotion de la santé, la prévention des maladies. Ça n'avait pas été le cas jusqu'au début de la pandémie de Covid-19. Ce qui s'est passé maintenant avec la stratégie approuvée par le président, c'est pour l'instant limité au Covid-19, donc un paiement des agents de santé communautaire pendant le Covid-19. Ces ressources sont du budget de l'État, du budget propre à l'État, mais le plaidoyer continue pour que ce paiement aux agents communautaires se poursuive après la pandémie et soit étendu à d'autres aspects du travail des agents de santé communautaire. Thank you.
Thank you, Flavia. Dr. Jessica, if you would like to very quickly add some few words, please do so.
She seems to have dropped off the call.
Hello, I'm here. Thank you very much. Sorry, I had a problem with it. I think what Flavia has said is a very exciting.
I think we have the issue with like video and recording. So let's move on. So our next question is to Senegal team. The question is about in the context of COVID, the suspicion, confirmation of severe pneumonia is important. Do you have data on number or proportion of acute respiratory disease cases treated on-site and referred? Senegal team, would you like to take on that? But before that, Bene, please translate.
Thank you. Sorry. Dans le contexte du COVID, can you repeat the question, Tamako? I cannot find it in our shadow. Can you repeat the question, please?
Yes, so in the context of COVID, the confirmation of severe pneumonia is important. Do you have data on the number or proportion of acute respiratory disease cases treated on-site and referred?
OK. Dans le contexte de COVID, la confirmation des cas de pneumonie est importante. Est-ce qu'on a des données ou des ou des informations sur les cas qui sont traités dans les facilités et qui sont confirmés pour faire la distinction avec le COVID?
Voilà. Merci. Pour les cas de pneumonie, nous avons les données dans le DHIS2. Nous avons les données des cas référés, des cas graves. Il y a également un bulletin épidémiologique hebdomadaire dans le cadre du SMIR où on suit les cas de pneumonie. Toutes les semaines, les cas et les décès par pneumonie sont suivis. Nous avons cela dans notre base de données. Merci.
Alors oui, les données existent dans le DHIS2, pardon. The data exists in DHIS2, and they do exist to make the distinction between the pneumonia case and the COVID cases.
Ah d'accord, bon, on ouvre le...
Go ahead. Allez-y.
Bonjour. Nous pouvons vous communiquer ces données des cas de pneumonie traités au niveau primaire et aussi des cas référés. On va ouvrir le DHIS et vous communiquer ces données.
So Senegal is happy to communicate.
Durant le 2020.
Okay, Senegal is happy to communicate this data about the pneumonia case that have been at the primary level and also the one that have been referred during 2020.
Thank you, Benem. Thank you, Senegal team. So we will have this communication continued in a community of practice, and Senegal team will communicate and share this data to everyone who is interested. So now we move on to Uganda team. There is very interesting question in terms of how Uganda team used experience from Ebola preparation and response and embedded as a success to the COVID response. Bene?
Yes, so a question for the Ugandan team and people are interested. Sorry, pardon. Une question pour l'équipe de l'Ouganda. Les gens dans le webinaire s'intéressent à votre expérience que vous avez de l'Ebola pour la prévention et la réponse à l'Ebola et comment vous avez incorporé cette expérience dans votre réponse pour le Covid-19.
Yes, this is Maureen from Uganda. Thank you very much for the question. Already during the Ebola preparation and response, we had task force frameworks that were already in place, the coordination frameworks like the National Task Force and quite a number of incident management teams that were already placed out for Ebola response, but as well as guidelines speaking to infection prevention and control at the different sites and how management can take place during the period of COVID. So these structures that were already in place strengthened and eased our management, especially just moving into COVID as these are also outbreaks and epidemics. So all these teams that were already placed out, this quickened the response and the frameworks that were already in place also made the work quite easy. Thank you.
Thank you. So c'était Maureen qui expliquait que effectivement l'apprentissage ou ce qui restait de l'expérience de l'Ouganda avec Ebola, c'est des structures qui étaient déjà en place, des structures pour la réponse, des task force et aussi des équipes de réponse immédiate. Et ces structures-là étaient déjà en place quand Covid a débuté, quand la pandémie a débuté, et on peut être renforcé pour la réponse à la pandémie du Covid. Over.
Thank you, Bene. It is very evident that both Uganda and Senegal team has managed to quickly adapt and maintain some essential services in terms of coverage and continuity. Now the question to Senegal team. Would be great to hear more about the transport systems to ensure quick referral on severe cases of childhood illness and pregnant women. I think many countries have been challenged with this during COVID.
Il est clair, d'après ce qu'on a entendu durant ces présentations, que le Sénégal comme l'Ouganda ont réussi à s'adapter très vite et à être innovateurs quand il s'agit de répondre au Covid et de maintenir la couverture des soins et la qualité des soins. Une question pour le Sénégal, ce serait bien d'en savoir plus sur votre système d'orientation des patients et comment vous avez organisé ça. Tama, you mentioned a task. Did you say task force or did I mishear that?
No.
Le transport, ok. Et le système de transport, d'orientation et de...
Transportation.
Yeah, transportation, sorry. So, le système de transport pour l'accès aux soins et le système d'orientation des patients et comment vous avez fait face à cette difficulté pendant la pandémie. Ça, c'était une question pour le Sénégal. Est-ce qu'il y a quelqu'un de l'équipe du Sénégal qui veut répondre et prendre la parole?
au Sénégal, à l'entrée de chaque structure hospitalière. Allô?
Oui, on vous entend.
Bonjour. Bonjour.
On vous entend bien.
Donc, il faut dire que l'organisation du suivi des patients s'est fait à plusieurs niveaux. Il a été mis en place un dispositif à la porte de chaque district sanitaire avec des agents de santé communautaire qu'on appelle les agents de la Croix-Rouge et avec le thermoflash. Donc, chaque personne qui entre à l'hôpital est flashée. Et là aussi, on exigeait le port de masque, mais aussi l'utilisation de gel hydroalcoolique. Ça, c'est à l'entrée de l'hôpital. Maintenant, au niveau aussi des sanitaires, il y avait aussi un système de distanciation sociale entre les patients, ce qui permettait un peu de respecter les mesures barrières. Donc ça, c'est vraiment fondamental. Maintenant, il faut dire aussi qu'il y a ce qu'on appelle la définition des cas. Le cas de COVID-19, là aussi, si un patient, par exemple, venait pour suspicion de pneumonie, ce qui se faisait, c'est le diagnostic de la fièvre. C'est pour voir est-ce que ce cas répondait à la définition de cas de COVID-19. Si ça répondait au cas de COVID-19, le processus se poursuit pour l'identification et le test pour confirmation. Et si ce patient ne répondait pas à la définition de cas, on le prenait en charge conformément aux recommandations. Mais il faut dire aussi que le personnel de santé devait respecter les mesures barrières en respectant la distanciation physique, mais aussi en utilisant le gel hydroalcoolique et le port de masque obligatoire. Donc là, c'est voilà de manière vraiment ramassée le suivi du patient dans cette phase COVID-19.
Merci beaucoup. Donc, la réponse du Sénégal, c'est que le suivi du sorry. So the answer from Senegal is that the tracing and of patient has been taking place at several levels. The first one is at the very door of each health facility. There was what they call a flashing system where everybody was screened, and that happens at the facility itself. And then there was also the fact that every patient had to use mask and hand sanitizer. The second level was social distanciation within the facilities between the patient, and then there was also triage being effected at the entrance to try to identify which were potential COVID-19 cases and which were not. So the first triage would then result, if necessary, to a COVID test. And then the fourth level was that the health worker themselves had to keep the barrier gesture to the distancing and the mask and the hand sanitizer and hand washing.
Nous voulons juste compléter le transport durant cette période. On sait que le transport a posé problème durant la période de restriction, où il n'y avait pas de transport interurbain, il y avait le couvre-feu à partir d'une certaine heure. Maintenant, ici au Sénégal, on a autonomisé les régions. Le gouverneur était autonome pour prendre des décisions avec son staff et en premier conseiller le médecin-chef de la région. Maintenant, les solutions locales, on vous a montré dans la présentation l'exemple de la région de Kaolack, les gouverneurs. Voilà, l'exemple de la région médicale de Kaolack qui a mis en place un système d'appel transport. Ça a démarré avec les femmes enceintes. À tout moment, si une femme a un problème et un travail ou bien est en situation d'urgence, ils appellent sur ce numéro et le véhicule vient chercher la patiente. Maintenant, les équipes étaient organisées pour renforcer le district. Tout ce qui
Dr. Aïssatou.
Oui. Oui. C'est bon?
Dr. Aïssatou.
Oui. Un dernier point aussi, les maires, c'est-à-dire au niveau des communes, il y avait une organisation pour les urgences. Comment transporter les cas d'urgence. Dans beaucoup de localités, le maire a mis à la disposition de la communauté un véhicule pour ces situations d'urgence.
Dr. Aissatou, thank you very much. We have to move. We will pose your question in English in community of practice. Now I hand over to Dr. Pawani Ram, who will conclude the session. Thank you very much.
Thank you very much, Tamar, and thanks to both the Senegal and Uganda teams. We've heard some very practical information from both teams today on the strategies they have been using to sustain ICCM and IMNCI services during the COVID-19 pandemic. We hope that the pragmatic approaches described by the two teams will be helpful as you continue to support the quality of care for women and children. And here on this slide, you can find resources on maintenance of essential health services, continuity of community care, as well as monitoring the effects of the pandemic on essential RMNCH services. Please do access these resources in order to support your work. Collègues, aujourd'hui, nous avons entendu des informations des équipes du Sénégal et de l'Ouganda sur les stratégies pour soutenir les services ICCM et PCMA pendant la pandémie. Nous espérons que les approches pragmatiques décrites par les deux équipes vous seront utiles alors que vous continuez à soutenir la qualité des soins pour les femmes et les enfants. Vous pouvez trouver des ressources sur le maintien des services de santé essentiels, la continuité des soins communautaires, ainsi que la surveillance des effets de la pandémie sur les services essentiels de RMNCH. Veuillez accéder aux ressources des sessions précédentes. Next slide, please, Elizabeth. Veuillez accéder aux ressources des sessions précédentes de cette série et continuer à rester engagé dans la conversation à travers la communauté de pratique. Please access these resources from prior sessions in the series and do continue to stay engaged in the conversation through the community of practice. This is the concluding session of this series on maintaining quality of care for MNCH services in the time of COVID-19. However, a number of webinar series continue through the Quality of Care Network, and so we look forward to seeing you. Please stay engaged with us in the community of practice. Merci à tous. Thank you, everyone.